This is Prof Gribben reporting from a very warm Milan, where we're at the European Haematology Association meeting. I'm joined today by Prof Mulligan from Sydney and Prof Hillmen from Leeds, and we're going to update you on some of the things that we've been hearing new at EHA, as well as touching also on some of the things we heard at ASCO just last week. Exciting times in CLL, I think we can safely say, in terms of the new drugs which are emerging. And of course, one of the big breaking news here was the results of the long-awaited randomized trial looking at ibrutinib versus ofatumumab. You presented that data, Pete. Do you want to take us through what's the highlights from that study?
Yeah, as you say, I mean, we've had phase 1, phase 2 data on ibrutinib in CLL for probably, 2 or 3 years now, and we presented the RESONATE trial, which is the first of the randomized phase 3 trials in relapsed refractory CLL. So for a relapse trial, we included 391 patients who were randomized between oral ibrutinib versus ofatumumab at the standard dose for relapsed refractory disease, and included patients who were really unsuitable for chemotherapy, either because they'd failed chemotherapy before, and they'd all failed chemotherapy before, or 17p deleted, or too old to have fludarabine-based chemotherapy. The results of the trial were that there was a massive difference really in progression-free survival. So in the interim analysis, the trial was closed. The median follow-up was 9 months, just over 9 months in both arms of the trial. In the ofatumumab arm, the median progression-free survival was just over 8 months, and virtually all the patients had progressed by 12 months, which is what we'd expect from the phase 2 data of ofatumumab. With ibrutinib, over 60% of patients remain progression-free at 12 months, and in fact, over 85% of patients remain on therapy. So even the ones that were technically progressed were actually still responding to the treatment. The subsets, if you like, the resistant patients, the 17p patients, all showed a significant advantage in progression-free survival as well. And the overall, which I think was very impressive, the overall survival data, given that 57 of the patients in the ofatumumab crossed over to ibrutinib, showed a significant improvement in overall survival, with 57% reduction in deaths in the ibrutinib arm compared to the ofatumumab arm. And once you go into ofatumumab, the curve plateaus out in the same way as ibrutinib, so that it looks like it helps those patients who cross over.
I guess in many respects, the study almost a victim of its own success in that it hit the endpoints so rapidly that we don't yet have terribly long follow-up. And I guess that's an issue that we'll come back to talk about with all of these novel agents, is that although we're clearly excited by the results, we aren't yet seeing long follow-up in terms of both the long-term effects on the disease control, but also the long-term effects of potential toxicity. Are there any kind of signals that you're seeing that are any concern, however, with the follow-up that we have?
I think you're right. I mean, you sort of allude to the fact that we're trying to get these trials done quickly so we can really get the benefits to patients as soon as we can, but we have to really watch the long-term toxicities. So in terms of the toxicity in the trial, the drug was ibrutinib was very well tolerated, and we saw adverse events, but very few patients stopped because of the adverse events to stop therapy. The only significant adverse events was an increased risk of mainly bruising and petechiae, and that was seen in almost half of the patients. But there was all grade 1, largely didn't cause a problem, and only one patient stopped because of a bleeding problem. And actually, in terms of grade 3 and 4, so serious bleeding complications, they were balanced between the two arms. So
yeah, that had been a previous concern from the phase 1-2 studies. I guess the value here of doing the controlled study is to suggest that we weren't seeing any additional signal over the ofatumumab, suggesting it's probably more related to the disease itself and the patient population rather than to anything to do with ibrutinib.
That's right. And then the other major issue, I think, well, not major issue, but thing we have to be aware of is that there's an increased risk of diarrhea in the first month or 2 of treatment. But this is very self-limiting, doesn't seem to cause a problem, and doesn't usually require intervention, and then over a month or 2 usually disappears.
Sure.
So diarrhea and arthralgias are the most common complications, but both of them relatively mild in degree. Yeah. And there was also this small group of patients that developed atrial fibrillation on the drug that probably wasn't that well recognised previously.
So maybe again a class effect of the kinase inhibitors.
So about 3% of the patients in the ibrutinib arm developed AF, and Actually, 4 of those patients had already had preceding atrial fibrillation, and 8 reverted to sinus rhythm anyhow, with treatment or without, and only 1 patient stopped because of the arrhythmia. And so I think it's manageable, but it's clearly was in excess of the atrial fibrillation seen in the ofatumumab arm.
Let's see, we've also seen data presented about the ibrutinib failures and are beginning to understand some of the mechanisms whereby that may be occurring. Do you want to tell us about that?
So look, there's been a couple of presentations, one from John Bird's group looking at ibrutinib failures, and they tend to fall into a number of different classes. There's patients that develop Richter's syndrome, and they tend to develop fairly early. And then there's those with disease progression of their CLL, and they appear to occur relatively late. And of the 6 patients that were tested by next generation or deep sequencing, in fact all of them had a mutation in either the BTK molecule or the PI3 kinase molecule.
PLC gamma 2 was the downstream.
That's right, yes, correct.
So I have to say, when we looked at the RESONATE trial, so the randomised trial, relatively short follow-up as you mentioned, but Richters tend to be early. There were 2 Richters in each arm, so there was no imbalance. So I suspect that the Richters is not due to the drug, it's more to do with the very poor patients that are going into these studies.
Indeed, possibly even an unmasking of them, in fact.
But I guess the BTK mutations particularly demonstrate if you put real pressure on one molecule, there's going to be a risk of a mutation occurring.
That's correct.
Although it's very rare to date in follow-up.
So you're right, I mean, so it seems rather rare, but it would, maybe you think about suggesting that using single agents aren't the way to handle relapse refractory disease patients who often have lots of clonal heterogeneity. There are, of course, other kinase inhibitors that have been reported on here. So do you want to comment on how you see the results with the idelalisib combination versus rituximab that's been presented?
Well, that's been presented at the in the New England Journal of Medicine just recently, as well as at ASH last year. There's a little bit of an update on that, but it really hasn't changed the fundamental outcome for that group of patients to any significant extent. Except for the slightly longer follow-up. There's a couple of other BTK inhibiting molecules around, but I think broadly they could be said to have fairly comparable outcomes at this point in time. And most of those studies have been on fairly small numbers of patients so far.
Sure. And we're talking also about the usual problem of relatively short follow-up. Do you want to comment at all on the side effect profile as you see it between idelalisib and ibrutinib?
I think the difference, and we're going to see this with different molecules, even targeting the same sort of BTK, for example, because they have off-target effects as well as the on-target effects. So with idelalisib, we tend to see the diarrhea tends to be late, and in occasional patients can be very severe and can almost can be colitic, and that is something that needs watching and managing. So we have to watch and stop the drug early if there's clearly an issue. And there's a slight concern over whether there's some pneumonitis with PI3 kinase inhibition, again late. I think the responses in the 116 trial, the randomised trial, are impressive as well. And so, you know, you have to take these things, you know, beginning to see some very bad groups of patients, and they're getting generally very good responses, and we're seeing some minor reactions. I think with ibrutinib, we mentioned that the RESONATE data really mirrors what we've been seeing with the phase 1, phase 2 data. And going out long term with those drugs, I mean long term, 2-3 years, there aren't any major issues that seem to be evolving on the drugs. We have to look at things like immune suppression and the immunoglobulin levels and what's going to happen if you're on these drugs for many years, because obviously that's a concern.
Sure. The other molecule that's generating a lot of excitement in CLL, of course, is ABT199. So John Seymour kind of updated us at this meeting on the results of the single agent study. So what are you thinking about this molecule, and you know, is it worth the hype that the molecule is getting?
Well, it's clearly a very interesting molecule, and it's clearly a highly active agent, and there's a range of data that's emerging. Again, it's still on relatively small numbers of patients. Obviously, we're awaiting the data on the recently closed 17p deleted patient trial, and there's the relapsed refractory trial that's still got a short way to go.
Sure.
But it's clearly a very interesting molecule. And on that note of potential resistance mechanisms, there's a abstract by Arnon Kater and Eldering from the Amsterdam group looking at possible mechanisms of resistance to ABT199, and they noted on an in vitro system that CD40 stimulation actually gave resistance to ABT that was actually overcome by dasatinib blocking, but not by ibrutinib blocking of the BTK molecule. So I think it's very interesting to look at the mechanisms that are going to be involved when these drugs come into more wide utilisation.
So Andrew Roberts presented the first time we've seen the presentation anywhere of the ABT in combination with obinutuzumab or GA101. You're treating patients on that trial right now. What do you think of that combination, and what do you think we're looking for to try to achieve in that combination?
I think combinations with small molecules with antibodies is going to be very important. I think from the ABT199, the management of tumour lysis has been important, and I think the modifications, and we've heard some of that data at this meeting, have really shown that we can manage single agent ABT199, by doing a slow gradual increase and watching patients very closely. I think with the anxiety with combining the drug is, do you then create more tumour lysis because you prime the cells to trap apoptose? I think the data from the Andrew Roberts trial suggests that is manageable, which is of course encouraging. There may be some additional tumour lysis that needs to be watched very closely, but I guess we're going to be moving towards combining the B-cell receptors and 199. So the real strength, I think, of 199, as well as the fact we're seeing really deep remissions with a single agent, is that the activity is clearly going to be complementary to the other drugs that you mentioned. So together, you'd expect them to be much more efficacious, but we have to manage the toxicity.
Now, thinking of combinations of these agents, I mean, one concern, particularly for those of us working in managed healthcare systems, are going to be the cost of these agents. They're very expensive as marketed within the US at the present time. And if we start thinking about putting them in combination, are those affordable for our patients within the systems that we have?
I think we have to look at ways to well, it's not just cost, I think, Don. I think what you have to look at, we've got patients who are going to become resistant if they're exposed to or potentially long-term drugs, and combinations may avoid that resistance. Patients don't want to be on treatment and coming to see us every 3 months or more often. They'd rather be, if not cured, free of the disease for a long period of time, and then be monitored occasionally, I'm sure, without the toxicity of continuous therapy or potential toxicity. And then, of course, is the cost. So I think what we need to be looking at is getting these drugs to the patients who really need it now. The 17P, the patients who have very poor survival, those patients need to benefit now. And then for the rest of the patients, and the patients who will benefit from these therapies, we need to be looking at how can we combine them to get to endpoints that allow us to stop treatment. And I think MRD eradication, which is becoming a much more robust, well, it is a robust assay, we're getting better assays for it, would be the endpoint. So we've got to look at combining 2-3 agents together to achieve MRD eradication, and then at some point stop the agent so that it's affordable. So
triple the cost for a defined period being a better way than continuous therapy, for many years for these patients.
And that's why the ABT199 rituximab start to the combination is so important. We have to get to these combinations and do it in a controlled way.
Sure.
I agree very much with Pete. There's a cohort of patients that have got early relapse after FCR therapy that have got a very high level of unmet clinical need. It's very important to get those agents out to those patients. One of the other things that has appeared in the meeting is a number of health economics issues, looking at life-adjusted quality of life, showing that with rituximab, for example, as well as GA101, that there actually is a positive benefit for that. Those studies with the small molecular inhibitors are probably a bit early to look at in that sense, but no doubt that's what we'll need to look at, as well as the health regulatory authorities.
Thinking of looking ahead, Stephen, you've got a big meeting coming up in
Indeed.
down under next year, so
Indeed,
we're
we have, John.
all looking
Yes.
forward to IWCLL going south of the equator for the first time ever.
That's correct.
So when's the meeting?
So the meeting is the 7th to the 9th of September in 2015 next year in Sydney. The Young Investigator meeting is going to be on the 6th on the Sunday beforehand. And as you say, it's the first time it's been held outside of North America and Europe, and we're very excited to hold the meeting there for the first time.
We all have our koala bears, absolutely.
Come and meet our koalas in Sydney.
So, what I think I'm hearing from you is a huge amount of excitement in the CLL community on the back of these very exciting agents, based not just upon their efficacy, but in the fact that we've finally got agents which are based upon the biology of the disease. I think we're all really excited as that we're hearing more and more updates with each subsequent meeting, and I think we can all look forward to hearing more in the future. So with that, this is Prof Gribben reporting for eCancer from EHA in Milan, and thank you very much for your attention.